Welcome to the OPA webinar, Telepsychologist Competencies for Psychologists Practicing in Ohio. I'm Joan Bowman, OPA Director of Membership and Education. I'll point out a couple logistical details real quick. For those of you who have joined us so far, your phone is muted on entry, so you don't have to worry about background noise or anything. If you need to ask questions, you may have noticed there's a little blue heading chat box in the lower left corner of your screen. So you can ask you can type a question in that everybody sees, or choose for just the presenters or just the moderator. So as we go along, if you want to type questions into that box, then the presenters will just decide if it makes more sense to answer it then or save it for the end, sort of depending on where they are in the topic. In order to receive your CE credit for today's presentation, you'll need to pass the webinar quiz. The quiz and answer sheet will be emailed to you at the end of the webinar. Return the completed answer sheet with payment, get a passing score of at least 80%, and you'll receive your CE. Please allow 1 week for the credit to appear in your MCE record. Today's webinar was developed by Drs. Cynthia Van Kuren, Mark Dielman, and Paula Ash. Dr. Van Kuren is the director of the Pain Management Center's Intensive Outpatient Program at the clinic BAMC. For the past 4 years, Dr. Van Kuren has developed and implemented pain psychology services via video teleconferencing at 6 outpatient centers affiliated with the Cleveland BAMC. She's also a facilitator for Scan Echo, a national project promoting specialty care in rural areas through telehealth trainings. Dr. Dielman is a psychologist from Sylvania, Ohio, and co-chair of the OPA Communications and Technology Committee. Dr. Dielman was involved in the writing of the OPA telepsychology guidelines in 2010 and was also instrumental in the writing of the 2013 edition of the OPA Telepsychology Competencies. Dr. Dielman has a private practice in Sylvania, Ohio, where his specialties are in working with emotional, behavioral, and attention and learning issues in children and adolescents, as well as assessment for memory loss and bariatric surgery in adults. He's also an adjunct instructor at Bowling Green State University and Spring Arbor University. Dr. Ash has been a member of the Communications and Technology Committee since it began addressing concerns related to telepsychology and has been very active in addressing continuing changes in this area. She has made significant contributions to the policies and formal documents developed by this committee. Her current interest is in the use of video games for brain and body exercising, education, and research. At this point, I'll turn the presentation over to Dr. Dielman.
Thank you, and I appreciate everybody joining us today on this topic. Interesting, historically, it was 2 years ago that a few of us, actually it was election day night 2012, that 3 individuals on the committee met and started talking about competencies, because I was inspired in the spring of 2012 by a presentation by Dr. Marlene Mayhew, and we'll talk about her later. She's owner and president of the Telemental Health Institute, and at that conference in Hamilton, Ohio, there were some psychologists in the audience who were asking what kind of competencies were available in Ohio, and so that's part of what inspired our committee to start developing these competencies. And I want to acknowledge a few people. So Audrey Ellenwood, Jeannie Jenkins, and Paula Ash, and myself, over the period of 2012 for a year, 2013, we met, some combination of us met for a year in developing these competencies. And I also want to thank Paula. I want to thank Paula Ash for putting together this PowerPoint. She was the major person who did that. The other thing I want to invite other attendees today is, if you want to be involved in the CTC, Communication Technology Committee, we welcome anybody that's interested in that. We meet the second Wednesday at 8 o'clock in the morning and meet for about a half hour. So if you're interested in that, my email will be available, I think, when you receive the quiz later. The other thing I want to bring up is that if, as a member of OPA, if you get on the member website and log in, right under the Board of Directors portal, you see a topic called Professional Issues and Resources. And if you click onto that, you'll see a list of topics on the left-hand side. If you go down to the bottom, you'll see the area of telepsychology. So under the area of telepsychology are the areas of competency that we're going to be talking about today. So you'll see it pretty much in the same format you'll be seeing and hearing today. There's also the OPA telepsychology guidelines for 2010 that Joan mentioned. Those are listed there. The Ohio telepsychology rules, we have a state law regarding telepsychology in Ohio, and those are listed there. And there's also a document, a social media document that was developed by a psychologist in California, Dr. Keely Combs, that really provides good information for psychologists who want to set up something related to social media for their clients. Also, this committee is working on an informed consent form. So hopefully, within the near future, this form will serve as a template for those in practice that they can use that for clients that they might be doing telepsychology with. So let's go ahead and get started here. And I'm glad that Cindy Van Kuren is joining us. I think Cindy is doing in telepsychology what many of us in private practice just hope and dream of. So she'll be adding her insights as we go along. So if we look at the objectives for today, we're going to learn about practical applications for the use of telehealth services, which Cindy will be talking a lot about, to be familiar with Ohio competencies for telehealth practices, and to be aware of current telehealth practice. So basically the outline indicates 5 different areas, and these are, again, on the competency that you can find in the OPA website. We're going to look at technical skills, clinical skills, online relationship with the client skills. If we have time, we'll maybe look at some supervision skills and also the online professional development requirements. So let's start by talking about the first part, the technical telepsychology skills that are really needed to develop a therapeutic relationship via a technological means. So what you'll notice in these PowerPoint slides, and this is how we developed it. On the left-hand side, you'll see the knowledge that's involved and required for the psychologist and or the client, and then the skills involved on the right-hand side. So one of the things that's pretty important foundationally for us as psychologists, if we're going to do telepsychology, is to know the guidelines. And those were developed over a number of years. And I was involved in that. Paul was involved in that. Ken Drude was a key person involved in that. So it's important for us as psychologists to take a look at those, to be guided by those, clearly to look at the telepsychology rules that are both on our website as well as the State Board of Psychology website. The areas of competency, which we're talking about, which became official about a year ago. And then also APA has developed some guidelines, and so you can also look at those. If you're interested in doing video conferencing, then you might want to look at that last area in the bottom, the 2013 video-based online mental health services. And all you have to do is Google that, and it's about a 21-page document for those who are interested in doing video conferencing. So one of the things we want to talk about a little bit is evolving technologies. And I think where this is going to become important is if you decide to do some training. One of the things that we're working on in our committee, and actually the OPA board has approved, is to we're going to be promoting the Telemental Health Institute training provided by Marlene Mayhew. She's kind of the first lady of telepsychology, if you will. And so there are some certifications involved through her program. So if you Google Telemental Health Institute, you'll find a lot of information. And so OPA psychologists will have the opportunity, if they want to take the full training with Dr. Mayhew, they can get a 30% discount. Just to give you an idea, it's 49 credit hours, and it costs about $1,356. So 30% off would make it about $1,000. And if you just choose to do one class at a time, you'll get a 10% discount. So Dr. Mayhew is clearly on the cutting edge of these evolving technologies, so it'll be important, I think, for us as psychologists to become aware of her services and maybe take use of the classes that she offers. Certainly many of us are already doing some form of telepsychology. If you've ever talked on the phone with a client, if you've ever emailed a client or texted a client, you've already been doing telepsychology. And so Obviously, video conferencing is kind of another kind of telepsychology. Most of us have already been doing some element of telepsychology, and I went to a seminar in March. Dr. Ken Drude spoke, and he's actually going around the state speaking. If you get a chance, he does a 3-hour workshop, and one of the things that Dr. Drude suggests is to just start slow. And so if you're looking to get involved in this area of telepsychology, you might want to look at some clients. If you have any clients that have medical issues, you might actually be able to get insurance to approve your phone sessions with them or email sessions or some kind of telecommunication with them. So it's important to start slow and just kind of build from there. And this is Cindy. Cindy, you want to talk about what you're doing?
Absolutely.
Right there?
This is an image of me doing a mock telemedicine session with my program manager. So I just wanted you to have a chance to see what the equipment looks like and what the setup would be. As you can see, this is actually a very nice set of equipment. This is an EX90 by Cisco. It's the third type of equipment I've used here. One of my favorite features is this picture-in-picture over here on the right. I work with pain patients, so I'm frequently demonstrating my spine model, body mechanics, drawing pictures of muscles, and I need to know what the patient is actually looking at. I also leave the picture-in-picture on to remind myself to always make eye contact with the patient. To make eye contact with a patient in telemedicine, you use this, sorry, I'm not so adept with this. You look directly into this camera up here at the top, and then wherever the patient is actually seated, it's going to look to them as though you are looking directly at them. This down here is what I actually use to dial into the session. It works just like a smartphone. You dial into the number that you would be using to reach the patient. And for privacy reasons, if someone else were around, you share an office space or something like that, I could pick up the receiver and just speak back and forth with the patient. This particular model also functions as a dual monitor for me, so it ends up being something that I've just really been very fortunate to have. But that gives you some sense of what it looks like on my side, and the patients are looking at something similar on their side as well. So with that, I'm sure I'll say more about that, but I'm going to send it back to Mark.
Just out of curiosity, Cindy, how much does that video conferencing equipment cost? Do you have any idea?
The rumor is it's about $10,000. So it may not be practical for someone in private practice, but certainly if you're in a hospital setting or something else, this is a really nice piece of equipment to have. I've had some other ones like the Jabber and the Movi where you just run it through your personal computer. I had some problems on mine with speakers and microphones. That's why I actually ended up getting upgraded to this nicer set of equipment. So it's something that, whatever equipment you get, you want to make sure it's working well before you start doing sessions.
Okay, thank you. So forms of communication, obviously two are the major forms of telecommunication would be the asynchronous and the synchronous. And so the asynchronous is basically there's a lag, and we know that in terms of email and chat rooms, message boards. So you could see how it could be used in a medical setting where there may be images related to dermatology, blood sugars, neurological exams, a number of things that could be sent where there's a lag and there's not, interaction at the moment. So, and maybe you want to comment about this, Cindy. You said something about you send materials.
I do sometimes. We're able to communicate with patients through their electronic record through a secured system. So I am able to send patients handouts, practice assignments, and those sorts of things to their chart. So that would be an example of an asynchronous contact. Okay.
And then the synchronous is more to in-person, similar to in-person visits. Appointments are scheduled, or the asynchronous, we don't need to do that. And so, obviously, there's a growing demand for mental health services. And Cindy, I'm assuming you do a lot of this with the military.
I do. This is anymore. I do more synchronous telecommunication with patients than I do seeing patients in person. This is a really significant portion of my practice, and I'm aware of other providers in the facility who are seeing patients who are active duty military overseas but need to see some sort of a specialty provider. So they're able to set that up for them.
So you're saying you are seeing more people in real time?
I do see them in real time on the television than I do here in person in my office.
I see. Okay.
Mm-hmm.
One of the things, too, that you should note, and some of the research suggests, as I was reading about, there's an individual, Mora, in 2008, found that the asynchronous communication apparently leads to more expressive and honest communication, while the synchronous communication also, because of the spontaneity of it, can also facilitate some pretty open self-disclosure. So Cindy, you want to talk about this a little bit, like matching your needs with the right technology?
I do. So I started doing telemedicine 6 years ago simply because we didn't have sufficient space for what we were doing. Our team kept growing, and we had more patients to see, and we didn't have any additional rooms to see them. So we started doing this out of practical reasons. But ultimately, the patients just prefer it. So now we do it because it's the patient's primary choice. So we had to look into what types of equipment work for our providers, and we all have some different types of equipment and different thoughts about what it is that helps us. We do have it set up so that I see a patient in telemedicine, but then they will also see the medical provider through telemedicine. So that's a service that we're able to offer, that the entire team will see them at the facility that's most convenient for them. Our patients go to the outpatient clinics. We do not have contact with them in our home for our service. There are other services that are doing that. But patients just find that it saves them the time from traveling all the way up here to Wade Park. They refer to Cleveland as the big city, and they don't like the traffic. So they'd rather go to the facility where they know the nurses, they're familiar with where they're supposed to report for their appointment, and that just feels better to them. It saves the patients the gas expense, and some of our patients are reimbursed for their travel expenses, and that's something that the VA has shifted their policy on as well. So we're just cutting back on expenses all around in terms of getting patients to an inconvenient location. Let's see them at a place that's more convenient. So in terms of technology, if you're going to see them at a facility like I am, you could certainly invest in some higher-end equipment because you're going to have multiple providers and multiple patients using that equipment. If you're seeing a patient in their home, you'd want to look into some other options that are more affordable for the patient, or if you're seeing something with less volume than what we're doing up here. And there's some different types of equipment available through the Telemedicine Buyer's Guide, and I believe they have an annual conference where you can also go and check out all the different types of equipment that are available. We in the VA are, of course, limited to what we have that's an approved vendor, but even within that, we have several different options of varying that meet our needs.
Cindy, do you any telepsychology in people's homes is always in clinics?
I only do it in the clinics. Now, our spinal cord injury unit, they will reach out to patients in their homes. And so they offer mental health services, medical services, and physical therapy to patients in their home, since obviously with spinal cord injury, transportation is a bigger concern. And we serve more than just the state of Ohio for our spinal cord injury patients. So it's just not feasible for those patients to come in anytime they have a need.
Okay. So one of the important things, obviously, we're talking about technology, is to be able to assess the client's ability. What is their knowledge of technology? Are they able to use technology? So, Cindy, do you know how that works in the clinic setting? Are clients instructed and taught how to use it, or how do you assess that?
Since I am seeing them in a facility, I have a person, either a nurse or a clerk, that's assigned to help me. They set up all of the equipment, they bring the patient back to the room for me, and they help with any sort of problem solving that I may have. I do talk to patients. Yesterday a patient was brought back while I was on the telephone, and he just decided he didn't like how things were set up and started manipulating things. So I do sometimes talk with them about how to adjust the volume, how to move the camera angle, but it's easier just to have a staff person do it if I have one available. But I need to make sure that they can hear me, that they can see me. I don't like for the picture-in-picture to be on for the patients. It's very distracting to them. But other than that, there's not a lot that's required of the patients on my end.
Okay, good. So obviously one of the things we need to assess is the client's skill, their understanding, their knowledge about telecommunications. So if we're just doing the asynchronous, we're doing email, chat rooms, whatever, then we need to be able to know what their knowledge is in those areas. So Cindy, would you talk a little bit about determining your resources?
Initially, when we first started doing this, I was very uncomfortable with seeing patients for the first time on telemedicine. So I was bringing them up to the Cleveland facility for the initial visit and then scheduling follow-ups in telemedicine. It was the patients who kept saying, couldn't we have done this the first time? The patients were very comfortable with it. So I had to work on my own anxiety and adjust my own expectations and made that shift. So now I will see patients, if that's their preference, I will see them from the very beginning in the telemedicine clinic. So I just need to make sure that I always have one staff person that is assigned to help me because I'm not there. I can't find a patient that hasn't been brought back to the room. I can't look at the MRI or anything else that they may have brought into me. I need someone that is there to help me. Obviously, the spinal cord injury team, where they're seeing patients in the home, they don't have that. They manage that differently. For me, what's been the most helpful in scheduling the patients is I have entire half days blocked to be in a certain clinic. I work out of 6 different facilities. And so every first Monday of the month, the Akron facility knows that I'm going to be there, and that they'll just keep bringing all of my patients back for me. They have the room reserved. They know to answer the call. And recently what we've been doing is we email back and forth with Microsoft Link, so they can just give me a heads up that my next patient is there or that someone has called to cancel. That's worked out very well. They get the same appointment reminders that they would get if they were coming to see me in person. So that's been helpful, and it does identify which facility they're to report to. If I have any concerns about a patient's appropriateness, I'll say a little bit more about this later. I always call the patient myself. I let them know what my concerns are, and I always just invite them to come to the Wade Park facility at that time. For my first set of equipment, for the first year I had it, I would drop calls nearly every single session. Very frustrating, and that was a problem with our bridge, not a problem with the equipment. So I learned as soon as they brought the patient back, I would have to tell them the plan for when I dropped the call and just invite them to just remain seated in the room, that I would handle it through other staff, and at least let them know what to expect because it made them very anxious. What happens if you or the client are running late? I will tell you I'm rarely running late, but again, I would just send a link to a staff person down there that could let them know. Or usually my patients bring their cell phones. I have called patients sitting out in the waiting room just to say I'm managing an emergency. I'll be with you shortly, and they've been fine with that. And I'll kick that back to you, Mark.
Okay, thanks. Obviously, beyond just assessing what the client's knowledge and skill base is in terms of technology, we have to look at what is the best approach, what is the best technological approach for their therapeutic services. So we have to be aware of any limitations they might have physically, medically, what is their language, what's their primary language, any cultural issues, clinical issues, and obviously access to devices and services that would permit both synchronous and asynchronous communication, which form of communication work better for them. So, Cindy, how do you go about assessing that?
You know, I don't get to manage my own caseload. So as I mentioned, I review all of my cases the day before, and I contact the patients where there's a concern. So if I see anybody who has active psychosis, if they really feel that it's hard for them to connect with providers and they're not very trusting, if there's anything where it just looks like they feel like they're not getting direct care that they want, I always call the patient. Like I said, I invite them to come in at the exact same appointment time just to come up here in person, and we work that out. After those phone calls, I can tell you I've only had one person in all these years who said they'd prefer to come up here in person. They appreciate the call. They want to understand what to expect, but at the end of the day, they do not want to spend 5 hours in the car with chronic pain to come up here. So we can usually work that out. And I do need to make sure that they can hear. I have had a couple of cases where the veteran just clearly cannot hear me no matter how much we adjust the volume. That's not helpful to the patient, and we need to make other arrangements for that. In a pinch, I just had somebody else that he consented to sit in the room and kind of just repeat what I had said. We worked it out, but that's not what we did long term. If I have a patient that's referred to me for testing, I just prefer to do it in person. I believe that there are ways we could probably reasonably do some elements of testing, a self-report questionnaire, we could work that out. But that's just my preference at this point, to either bring them in here or make arrangements with a psychologist at that facility to do the testing for me. So I always want to know what intervention has been planned for this person. I do get, because I don't manage my own schedule, I do get a number of patients who are scheduled in my telemedicine clinic for biofeedback. But my biofeedback equipment is up here at this facility. So again, I try to catch those, and I just invite them to come up here instead. That's not an appropriate intervention for telemedicine. But mostly I just want to make sure that it's something that they're comfortable with, that this is something that feels okay to them, or if they, would just, if that doesn't feel like a good way to establish a relationship, I'll always accommodate that.
Okay. As Cindy kind of inferred, we talked about some assessment, and like she said, probably she prefers to do it in person. And I think one of the things we want to differentiate here is there's certainly a lot of tests out there on the Internet. And the difficulty with any tests that our clients might be taking and then might be providing information to us concerning them is, are these tests reliable? Mm-hmm. Are they valid? Do they generalize to the particular client or patient with whom we're working? What's the norm group? And so that's one of the questions. We know, if you're familiar with some of the statistical information about the tests that typically psychologists use, the question is, does the same process go on in norming of the tests online? So I think one of the things we want to clearly do here is differentiate those kind of tests that are out there that are more popular, but that we might not use as psychologists. So like Cindy suggested, she would prefer to do it in person, or like she said, maybe there's other ways you could do it. I suppose you could give someone a Beck depression inventory video conferencing by just asking them the questions. So, or provide that document at the clinic or wherever they might be. It's a little tougher, obviously, if they're in our home, and I think generally what we recommend is that patients and clients don't take any of these tests at home. Mm-hmm. So, one of the things we also want to be aware of in terms of the testing is, making sure that standardized instructions are being used. I think I went too far here. Let me jump back here. What kind of procedures are used, because obviously all the tests that are reliable and valid have certain procedures in both administering and interpreting them. So, I get a little concerned when these tests somehow, or test items, find themselves out in the public somewhere. So that becomes a concern. I would refer individuals that are interested back in the OPA telepsychology guidelines. We spent a fair amount of time talking about the whole area of assessment. So that would be something to, I think, refer back to if you're interested more on assessment areas. So electronic communication, this is obviously a big issue, security issues, right? When we're doing either assessment or doing therapy, how secure is it? I remember Marlene Mayhew at her workshop said that Skyping is basically like talking to somebody on a park bench, so not real secure. So, Cindy, can you talk a little bit about your communication and what you do as far as storing it and dealing with it?
So I don't actually store what I do for the, for telepsychology. The storage would apply more in our facility to dermatology, to some of the pictures that patients may be sending to their providers. There is an encrypted way that can be communicated to us and stored within the patient's electronic record. So it's available. It's just not something that I've had a need for with the type of work that I'm doing, and that is part of my informed consent that I explain to patients that I am not recording that session. So there isn't anything that we need to dispose of for the telepsychology piece that I do.
Okay. Can you keep talking a minute? My computer just went blank.
Oh, absolutely. So that would be something to think about if you're part of a medical team or something else, again, where you would just need to have more back and forth communication of protected information just to make sure that you've got an encryption service. I have seen that there are some universities that will actually provide a free encryption service, so that is something that's available just in an effort to protect patient privacy. So that would be out there as something that you could use in addition to the type of equipment that you might be purchasing.
So now I'm waiting for my computer to boot back up. Do you want to go on and talk a little bit about the telepsychology skills in part 2 there?
Absolutely. We'll move right on to clinical telepsychology skills. So you want to, of course, know how you're going to approach whatever service you're offering. If you're going to do therapy, if you're doing an assessment, you need some sort of a plan for that. And, of course, the clinical skills that you have are largely going to carry over. Cognitive behavior therapy is cognitive behavior therapy and so forth. There are some different sorts of skills that I've had to acquire through trial and error that I'm going to share, I think, on the next slide here. But I think that just like you would for anything else in your field, you want to maintain a consultation with colleagues and ask them about their experiences with telemedicine. I spent a lot of time doing that. Telemedicine is everywhere in the VA now, but it wasn't 6 years ago. So I spent a lot of time talking to my colleagues about what they were doing to establish rapport over the TV and how were they maintaining follow-ups and was it important to them to have some direct in-person contact. It was really helpful for me to get their ideas instead of figuring it all out on my own. There are some trainings that Mark has already mentioned, Marlene Mayhew. There are some other ones out there. They vary greatly in cost and perhaps also in applicability for what you're doing. So just make sure you check those out. And American Telemedicine Association does have some conferences. Ken Drude, as he mentioned, is very knowledgeable in this field and does a lot to promote the use of telemedicine services or telepsychology. And there's a growing body of literature, some very good research that's out there as well. And I know that Ken Drew does keep a list of that, actually, of all relevant articles that he's always happy to share. All right. Are you back? Okay. Okay. So in looking at how to conduct services online, you want to make sure that you're meeting the telepsychology requirements that have recently come out. And those are available online as well. And I think what I'll go ahead and on this next slide, what I'll talk about a little bit are some of those other skills that I had to acquire. I think that one of the things that was different for me is that, we use our bodies in so many different ways to calm down an agitated patient, to wrap up an appointment for the patient that doesn't want to go. Those things don't carry over very well to telemedicine. So I had to do things a little differently. Instead of being softer for the agitated patient, I would be invisible. That doesn't work. So you actually have to be bigger and use dramatic hand gestures and try to do something to kind of interject your presence to these patients. The patients that don't want to leave, it's difficult because I can say, several nice ways of wrapping things up, but if they just want to sit there, they're just going to sit there. And so I've had to come up with some other clever ways to kind of make sure that they understand that we're finished and reassure them that they can contact me and so forth. I also miss silent tears. I can't see those on my screen. Even as nice as my screen is, the details are not sufficient for that. And so I kind of give myself longer pauses so that I can listen to the patient doing that. If they're crying, I need to be able to make sure I can hear it if they're crying without wiping their eyes or saying anything. So there's just those subtle changes that I think take a little bit of getting used to. As I mentioned before, always making sure that you're engaging the patient by making eye contact. Well, if you're looking into the camera, you're not looking at the patient. So that takes a little comfort to be able to go back and forth between the camera and the patient because I need to see them. They're showing me where their pain is. I need to watch for some things there. And, of course, for all of us, watching their affect and other anxious behaviors, so we need to see them. But sometimes, again, if I'll talk to the patients about what I'm doing, that it may look to you like I'm looking off screen, or I need to look up something in your medical record, I just keep them involved in the process and kind of say aloud the things that would be more obvious if they were in the room. So in terms of the additional skills, I'm going to kind of put that among it because it's different than what we're used to doing, but it's a pretty reasonable transition to still engage the patient over the screen. The other thing that I learned is if I walk out of the room for a minute and I come back, I need to know who is sitting in the room on the other side, because I have had that before where I'm 20 minutes into an appointment and I hear a cough or I hear something else off screen, that they may have brought family members and not told me and not acknowledged me, and then I'm not including them in any way. So I do just always check if a patient's brought into the room when I'm not present, sometimes when I am present if I don't have a good camera angle, just to make sure that I'm including everybody on the screen the same way that you would if they were in person. So otherwise I tell them I feel like I'm sitting with my virtual back to them. Oh, I do have a question that is very timely. So how do I end a session with a patient who does not want to go? So I do, of course, do my polite wrap up, here's what I'm going to do, here's what you're going to do. But if they really don't want to go, I just kind of reiterate that I've got another person waiting. I've really enjoyed talking with you. I'm looking forward to our next appointment. But, just reassuring them that they can contact me in between appointments seems to be the best way to make that happen. And eventually, just reiterating, I do have somebody waiting. I have one patient. He is very well known to the facility where I see him. I've never asked them to do this, but they know he doesn't leave. They always come and just get him. Say, Mr. So-and-so, it's time to go. The next person is here. So you can also coordinate with the people who are physically present to make sure that there aren't concerns about someone not willing to leave. And usually the people who aren't willing to leave, it's not because of any sort of agitation. It's more loneliness. All right, are you back, Mark?
Well, I'll tell you what. I'm not going to worry about the PowerPoint. I'll just talk. We're on part 3.
Okay.
Right?
I'll keep advancing us.
Yeah, keep advancing the slide. So we're on part 3. We're talking about the psychologist and client relationship. And one of the things we want to talk about, and this is an important part all the way through the therapeutic relationship with the client, is looking at the whole risk-benefit situation in terms of the online therapeutic relationship. We can't always assume that it's either better to do in person or it's better to do telepsychology with this client. So it's important just to evaluate that both initially and ongoing, and as well as the termination. So obviously one of the things we have to do is make sure we're complying with the legal and ethical requirements, state and federal. So again, we go back to our guidelines and we go back to the telepsychology law and to be aware of that. And I think as Cindy kind of talked about a few minutes ago, one of the things that perhaps is missing and that I see in some of the training that's out there that's offered is consulting with other colleagues. That's so important. So if you're starting in this whole area of telepsychology, you want to make sure that you're talking with other people who are already doing this or have done it at some time, so you can get good information about that. Just in terms of whenever we're trying to develop a competence in an area, we're always consulting with other colleagues. We're going to training. We're reading books. We're doing the training through Dr. Mayhew or other places. So continually upgrading ourselves in terms of our knowledge and skill areas. So I know one of the things that I came across when I was at one of the trainings was just the whole social media, and where some of us might be uncomfortable, and wisely so, dealing with clients in social media. There's younger psychologists are very open and very free and think they should be able to communicate with their clients or patients on social media. So there's things that we need to be aware of and just kind of the ethical challenges of all those. So let's move on to the initial stage of the therapeutic relationship. So one of the things that we've been talking about, and it seems like we're probably reinforcing this, is that what does the client need? What is the most appropriate therapeutic approach for the client? What are their needs? We've done this initial assessment. We know any physical or medical issues, as Cindy mentioned. We've hopefully assessed if they're psychotic or suicidal, which obviously in that case telepsychology probably would not be very helpful. So just looking at any cultural, language, medical issues, if they're agoraphobic and can't leave the house, then obviously they might respond better to this kind of approach. And also, what is better, the synchronous or asynchronous communication? So, Cindy, you want to talk about establishing rapport through technology?
Certainly, and this again is where my colleagues were so helpful, the more established providers when I first started doing this. That I just try to make it a little bit light in the beginning and just point out that we offer this because Wade Park is always under construction and we don't have enough parking and people just think it's too far away. Just try to kind of make it a little bit light, and they always agree because they don't want to come up here and have no parking. So that seems to be helpful. Then I go over what it is that, what they can expect from the appointment and assure them we're going to do all the same things that we would have done if they would come up here, and then ask them if they'd like to proceed. The VA does have a standard informed consent statement, and some elements of that are being considered for the OPA statement of informed consent that we're working on. So that's always helpful. I do assure them that they have the option to come up here and see me in person if they prefer at any point. They can always change their mind. I do have some patients that just want to see me more frequently, so we actually go back and forth. We'll do every other month telemedicine, alternating months in person. I also let patients know if they are coming up here to Wade Park for another appointment. If they give me a call, I'll just try to stop by and say hi to them in the waiting room so that they just can see me as a three-dimensional person. That does seem to really help them. And I do have a number of patients that take me up on it. They just want to say hi and shake my hand, and that's all they need. They seem to do okay. But I do think that if they're going to cry with me in person, they're going to cry on telemedicine. If they're going to yell at me in person, they're going to do it on telemedicine. I'm not really seeing discrepancies in terms of how emotive or connected the patient is to me. And just the nature of what I do, not a lot of patients are asking to see a psychologist because of their back hurting, but I really have a great record of follow-up. They still come in to see me. We've been able to do all the same things we would do otherwise, but I can reach a much bigger audience. I see patients throughout Northeast Ohio. Occasionally I'll get references from or referrals from other VA facilities in other states or other areas, and I'm still able to connect with those patients and provide whatever service they might be looking for. So if you're a warm person, that's still going to come through in telemedicine. If you're more, whatever your approach is going to still be evident to that patient. I don't think that gets lost.
Okay, so the initial stage, in a sense, on telepsychology, we're doing very much what we would do in our private practices or in our offices, where basically we find out what the client's concerned about and also develop some goals, or there hopefully are co-constructing goals with us, and also we describe the whole process. And so obviously talking about the option of in person, and Cindy, obviously you must talk about those options with them. And how do you decide whether to do in person or telepsychology or some combination of both?
So for the most part, I have more availability in telemedicine than I do here at Wade Park because of my other job responsibilities. And so if it's a patient that wants to be seen frequently, then they usually prefer the telemedicine. But ultimately, it's always up to the patient, and I don't, penalize them. If there's someone walks in the room and they really don't want to stay for telemedicine, I will overbook them that week and work it out, and then revisit the telemedicine at a later process. But that always seems to work out. Again, biofeedback, I always want them to be here in person. That's just the nature of the beast. But anything else, even if I'm doing some manualized treatment for cognitive behavior therapy for chronic pain, we can always work that out. I just send them the entire packet up front, and they just bring it with them to every session. And the only difference is I can't just read what they've written. We kind of have to talk it through. But other than that, again, it seems to be a pretty seamless transition between the in-person visits and the telemedicine.
And also one of the things that we both do in person in terms of telepsychology is the HIPAA policies.
Yes.
So, right, do you want to talk about that, the whole informed consent?
Sure. So I do let them know, of course, that they have the right to change their mind about telemedicine at any point. Nothing is being recorded. I'm in a private room. They are in a private room. We go over all of that, and of course, the limits of confidentiality I do discuss with the patients as well, and how I would manage any potential emergencies at that facility. And again, that is fine. I think I was planning to talk about it later, but I can give you just an idea of how I have managed emergencies in the setting. I've had a couple of medical emergencies. I'm able to call down there, have the medical team address them, and in those cases, they've ultimately been transported up to the nearest emergency room. But I have someone, again, because I'm at a facility, I have people that can do an assessment. For the mental health emergencies, again, I do what I can do to calm them down, do a safety contract, set up follow-up appointments in person. I don't have flexibility with my schedule in telemedicine. Always invite them to come up here. But if I really can't get them to a point that feels safe to me, again, I have access to staff down there that can step into the room and take over the visit. That between the medical and the psychiatric emergencies in 6 years, I'm going to guess that I've had 6. It's not been an overwhelming issue, even though I see a lot of patients through this modality. But again, that's something you'd certainly have to give thought to if you're seeing them from their homes.
Right. That's the question I have, right? So if most of us would be seeing someone through email or through chat,
right,
on the phone, what would you recommend in terms of setting up those emergency?
What I would do is I would make sure that at your intake, of course, you're establishing, their contact information and one or two other people that you could call in case of an emergency. But at each visit, I would make sure that I understand where they're calling you from or which, if they're at the Starbucks or wherever they may be. And of course, they may not be honest about it, but there's only so much we can do. I would at least make some effort to understand where they are, if things get to a point of an emergency, to make sure you know the local police for that person, local emergency contacts, or the family members that they may have provided to you.
So there would be a value for us and to know who the local mental health people are, police, right?
I think so.
Right.
Especially if the plan is to be able to reach people outside of your geographic region. Especially if you're a specialist and you're trying to reach some folks in a more rural community, I'd want to make sure you know who's available to help with that.
Do you talk a little bit, and I think that's the next slide, is the limitations of distance technology?
Yes. Did I fall behind?
Or I'm behind.
One of us is behind. Okay, I'm sorry. So the limitations of the distance technology would be, of course, if you've got a dropped call, if you've got, I'm not doing group therapy this way. This is my personal choice because a big part of my role is to explain that we are very conservative with the use of opioids, and in a group format, I just think I'm not going to win. I think they're going to turn off the TV and do what they like. I think it would be a very effective modality if you're addressing anything other than narcotics. So, again, knowing your audience, knowing your population, knowing your treatment goals, I think is going to make a difference there in terms of whether it's the right modality for you or not. I already talked a little bit about the testing. That's just something we've changed our approach here over the years, but ultimately it's just easier just to bring them in to do whatever testing that I want. You'd have to give some thought to financial arrangements and how you would want to be paid for those services if they are not walking into your office, and how you would manage any sort of a release of information. Again, I'm just in this setting where they can just walk down the hall and fill out what I need, or if they do bring in an MRI or something else they need for the doctor, I have a very easy way of getting that up here to me by the end of the day. That is not going to be the case if you're seeing patients at home. So you'd want to know how to exchange records and confidential information, or how to get those releases if you need to talk to other providers in their care. Did that answer your question, Mark? I know I missed a slide here. Okay.
I don't know. Where are you at?
Let's go to initial stage 3F.
Okay. 3F. Well, we had talked about the emergency plan, right?
We did, yes. So the other issue would be, coverage. You'd want to have a plan for that just as you would for your in-person practice.
Yeah. Okay.
Okay.
Let's talk about, have you had any equipment malfunction?
I have just that one type of equipment that we had that it really was more about the way that we were set up. We were growing faster than our bridge could accommodate, and so we were all dropping calls all the time, and that was frustrating and disruptive to services. So just make sure that when you purchase equipment that your software, your computer, the patient's computer can manage the type of communication that you're having.
So we're moving into the maintenance stage of the therapeutic relationship, and again, we want to assess progress, as we do both in our office and we would do telepsychology. So, is there progress towards the goal? And I don't know if other people use it, but I find helpful to use the scaling question that solution focuses people have talked about. So any way you can get a sense of what is the progress they're making, and looking at the whole idea of does it seem to make sense to continue to use telepsychology? How are they feeling about it? Are they satisfied with it? Do they want to continue to use it? Do they want an in-person session? Again, you have to ask whether that's practical or not. If they live 3 hours away, that might not be practical, or like Cindy was saying, people are afraid of the big city, so they may prefer to use the ongoing telepsychology. But I think you have to be sensitive to the patient and what their needs are and what they want.
Absolutely.
Okay?
Okay.
Go ahead.
Oh, and I was just going to say, with assessing their comfort with the technology, if it looks like they're uncomfortable, I try to find out what's going on, and it's almost always that the picture-in-picture was left on, and I will have someone come and fix that. But, I need to make sure that they can see me, that they can hear me, and again, just that they're comfortable with it. And turning up the volume is at least pretty low key, that they can usually address that. But yes, I always invite them to tell me at the end of every visit if they were okay with the technology and if they're okay with continuing that way, and it's almost always very favorable.
Okay.
Okay.
So, talking about termination, I don't know about most of you, but I don't remember too many classes in graduate school that talk about termination. But I think that's one of the things as psychologists we need to prepare for from the very beginning. In fact, I tell my clients my job is to work myself out of a job for you. So begin to think about that, and how will they know when they're done? And obviously that really does, I think, depend a lot on where the client is at. And like I said, I use the scaling question. So if I use a scale of 1 to 10, with 10 being perfect, when people get about 7 or 8, they're usually about ready to be done with therapy. And sometimes at one of the latter sessions, I will say to them, and certainly this would apply in terms of telepsychology, I'll say, well, we have a decision. We can either get together again to set an appointment. Secondly, we could set an appointment that you could feel free to cancel. Or thirdly, we don't have to schedule an appointment at all, and we can just kind of wait how things go. So certainly we want to be very aware, I think certainly as much or maybe even more in telepsychology, monitoring progress, how are they moving towards the goals, how satisfied are they with the technology. In a sense, I think we're a little bit like salespeople, without the negative side of it, in terms of, obviously telepsychology is something we believe in, we're trying to promote to them, but we also want to make sure that they're comfortable and satisfied with it. Okay, so, as we are thinking about terminating with a client, is there a follow-up plan? Do they need other resources? And certainly gaining feedback. And there's a number of, I think there's a session rating scale out there. There's outcome questionnaire, Lambert. There's a number of questionnaires that you can use to obtain their perception and satisfaction with telepsychology. So that's important. I know we're running out of time shortly here, but I did want to comment about supervision. And with supervision, we're talking about you as a psychologist with a supervisee and providing that supervision through telepsychology. So just a side note here, in the recent September 2014 APA Monitor, there were a couple of good articles about supervision. So that's something that we as a committee don't really talk about, and maybe as psychologists we don't do much in terms of knowing about that, but that's certainly an area that the committee wanted to address, and certainly this is something that's going on out there. So I know, Cindy, you said something about you did not do supervision per se, right?
Not necessarily. Not through the televideo conferencing. There was a project I was involved with 2 years ago for a manualized treatment rollout that we were doing around the country. And so I was supervising 4 other psychologists in different states. They would mail to me their sessions, and then I would listen to them, and then we would talk on the phone to do feedback. But I've not done anything with the video conferencing. I am involved with Project Scan Echo. It's a national project in the private and VA sector where we train providers in rural areas to provide specialty care. So I am on 2 pain management teams, one that's just for all of South Texas and a second one that's different states in the country. And we discuss cases and we do didactics every single week and just, give them ideas for providing pain management services and introducing the mental health component to that. So it's not supervision, but it's certainly case consultation that I'm doing twice a week.
Right. And I think one of the comments here, at least in our slides, is that supervision involves all the previous skills that we've talked about. So the relationship skills, the technical skills, the clinical skills, all of those things come to bear in terms of supervision. So the only other comment we might want to make is in terms of just the encouragement. Obviously, there's nothing in stone yet, but obviously continue to, for those interested in this area, need to continue to obtain consultation, ongoing training, continue to be familiar with any changes in ethical issues, the law, and all of those things. So I don't have anything else. Cindy, I don't know if there's anything you want to add.
Nothing else for me. We do have some training resources listed on one of the later slides here that you could certainly look into. And as Mark mentioned, you'll be provided with both of our emails if you had any other questions that you wanted to discuss with us.
I think we'll turn it over to Joan then.
Mm-hmm.
Okay, thank you so much, Dr. Van Kuren and Dr. Dealman. And especially Dr. Dalen, I have to say you were ready with your emergency plan because you're the first person I've had lose access.
And I didn't even have a contract with it. So,
so I really appreciate that. That is great preparation there.
Yes, it is. An in vivo demonstration of technological problems.
There you go. I need to get a new computer anyway, so this is a good reason for it.
Well, I'm sure it's busy updating and getting all ready for you to use it.
I did get back online for the last few slides, so I did.
Oh, good.
It needed a rest.
Okay, and thanks to the rest of you for joining us for today's presentation. You can view the rest of our webinar library by visiting our website at ohpsych.org. And please remember to return your completed answer sheet with payment in order, well, not with payment, you already paid. In order to receive your CE for today's presentation, you can contact me with questions at jbowman@ohpsych.org. Oh, actually, I'll forward this to the slide that has my contact information on it. Or the phone number is 614-224-0034. And as we mentioned before, I'll email the quiz and answer sheet out to everybody in the next 5 minutes. I did have 1 or 2 people who I think had my original emails go to their folder or junk mail. So if you don't, if you don't have it by 1:30 and you're looking for it, check your spam folder. But let me know if you don't get it. And so you'll be all set. I'll include Dr. Dealman's and Dr. Van Kuren's contact information with that, so you'll also be able to reach them if you have further questions. But thanks again for supporting OPA's webinar series. Enjoy your afternoon.